Okay, good evening, everyone. I'm Dr. Ashwini Singhal, uh, your mentor for the day. Welcome to all the students. I can see Dr. Tapas there. I think he is a fellow colleague. Um, Welcome, Dr. Tapas, as well. I hope everyone can hear me clearly.
Absolutely.
Okay, done. So today we look at week 7 of NNF Shine program, which, as all of you know, is a flagship program of National Neonatology Forum for all the first year postgraduate students across medical colleges of the country. And we are currently looking at the North Zone activities. Today we will discuss two topics: post-resuscitative management of asphyxiated neonate and neonatal seizures. To some extent, both these topics are interrelated to each other because seizures is a major complication of asphyxia, but then seizures can occur uh, in the absence of asphyxia as well. So let's start. If you have any questions, keep sharing them with me. I'll look at the chat box and see if we need to answer anything. Okay, parental asphyxia ranks as the second most important cause of neonatal death after infections, accounting for around 30% of mortality worldwide. Remember, asphyxia is more a problem of the developing countries, low and medium income countries, as is infection. So both are important causes of neonatal death, and asphyxia accounts for 30% of the neonatal mortality. The learning objectives for the day are performing initial stabilization and management of asphyxiated neonate. We will not go into the resuscitation details, but beyond resuscitation, monitoring of a baby with asphyxia and recognition of poor prognostic factors. What do we tell the parents of the baby that yes, your baby is going to do well or not going to do so well, or it just depends. Asphyxia has been defined differently. Asphyxia has been defined differently by different organizations depending on the ease of whether we are looking at the ease of the definition or whether we are looking at the medico-legal aspect of it. It could be gasping or ineffective breathing or lack of breathing at 1 minute, need for positive pressure ventilation for more than 1 minute, an APGAR score less than 3 at 5 minutes or longer. But the working definition which the Southeast Asia Regional Neonatal Perinatal Database used was for babies who are not born in your center, moderate asphyxia, slow or gasping breathing at 1 minute of age. It is just easy to ask someone, when did the baby start to breathe, or was the baby breathing at birth? When did the breathing establish itself? So that is an easier part of definition. Or a severe asphyxia is no breathing at 1 minute of age. So either slow or gasping breathing, which is moderate, and no breathing, severe. For babies which you have observed yourself, these are intramural babies, an APGAR score of less than 7 at 1 minute of age. Now, I really don't know whether most institutions continue to give APGAR scores to babies, but on a personal level, I can say that we have stopped giving APGAR scores to babies long ago, more than 10 years ago, because of obvious drawbacks of APGAR score. APGAR score has its own advantages and disadvantages, not going into that in this topic here. But yes, the definition used in that database was an APGAR score less than 7, moderate was 4 to 6, and severe is less than 3 at 1 minute of age. Remember, this is not a very scientific definition, but from a statistical point of view, this is an easy definition to remember. Now, if you were to go into the ACOG definition for asphyxia, now ACOG or American Academy of Pediatrics actually defined asphyxia more from a medico-legal point of view. Why medico-legal? That once we label a baby as asphyxia, this has medico-legal connotations. The parents could sue the obstetrician for the baby developing asphyxia. So this has to be a very, very strict definition. Remember, we cannot have such a strict definition for clinical purposes. But yeah, perhaps in many developed countries, medicine is dictated by law. So what are the criteria for ACOG definition? An umbilical cord arterial pH less than 7. Whether it is metabolic or mixed doesn't really matter. An APGAR score of 0 to 3 for longer than 5 minutes. A neurological manifestation following asphyxia, which could be seizures, coma, hypotonia, or anything, and evidence of multi-system organ dysfunction. Now, all these criteria have to be met. It is not one of these, it is all of them. So that is what the ACOG says. Then you can say that what the baby is going through is perhaps due to asphyxia. WHO just defines it too simply: failure to initiate or sustain breathing immediately after birth. So what is post-resuscitative care? I believe everyone is conversant with this diagram of neonatal resuscitation. Remember that if the baby has good breathing efforts, then this baby goes with the mother, and there is nothing that we need to do about this baby as far as active interventions are concerned, or shifting the baby under the radiant warmer is concerned. Just observing the baby with the mother is good enough. Now, for babies who require positive pressure ventilation, or babies who require any step beyond positive pressure ventilation, could either go for what we say observational care or a post-resuscitation care. A prolonged positive pressure ventilation more than 60 seconds is definitely an indication that this baby would need some degree of care other than with the mother. Now, how do we clinically monitor the baby who suffered asphyxia? One is assessing the severity of asphyxia, a clinical monitoring, minimizing the damage, that is, whatever damage has been caused by asphyxia, one go, then we don't let that progress, how to investigate and how to prognosticate. Now, asphyxia can have adverse effects on almost all organs. Most common organ involved is kidney. Remember that kidney is one of the first organs to be affected, and in the absence of a kidney involvement, chances of brain involvement are less. I'm not saying zero, but they are less. It could involve the heart, and it could involve the lungs. CNS involvement is characterized by seizures, lethargy, irregular respiration, hypotonia, or a frank coma. We also remember, I will not go into details of this picture, that preterm versus term gestation, there are different areas of the brain affected, and there are different manifestations of asphyxia in preterm and term gestation. Suffice to say that in term babies, you would have a more parasagittal cerebral injury distribution, whereas a deeper white matter is more involved in babies with preterm injury. So a spastic diplegia is more characteristic of a preterm brain injury due to asphyxia in preterm babies, whereas spastic quadriparesis is a more common type. There are many other types which I think is beyond the scope of discussing the clinico-pathological correlation of asphyxia. As I said, clinical presentation ranges from renal, which is acute kidney injury, the most common manifestation of which would be a decreased urine output in the initial few hours after birth. Hematological manifestation could be bleeding from any side. That could be due to platelet dysfunction, or that could be due to coagulation parameters derangement. A CVS, you could have shock or before shock, or just a cardiac dysfunction which is not manifesting as shock. Respiratory system, you could have a secondary inactivation of the surfactant and need for respiratory support, which may be more. The more the preterm or early term or late preterm babies may develop a respiratory distress syndrome, which may be mild to moderate to severe, because asphyxia inactivates surfactant. And these babies can have, because of the diving reflex, that is, whenever the blood supply to anyone is cut off, the blood preferentially goes to the brain rather than the GIT. These babies are more likely to have feed intolerance. Now, encephalopathy has been graded differently. I think you need to just look at one of these scores. I'll talk about three of them: Levine's and Thompson's and Sarnat. Sarnat perhaps is most commonly used because that was perhaps one of the first gradings of asphyxia, but you could learn any one of them. Levine's says that the encephalopathy could be mild, moderate, or severe, uh, depending on the level of consciousness, where the baby could be irritable, lethargic, or comatose. Tone, where the baby could be hypotonic, markedly hypotonic, or just flaccid. Seizures, where the baby has no seizures, has seizures, or prolonged or uncontrolled seizures. Sucking is poor, sucking is difficult, and there is absent suck. And respiration is spontaneous, the respiration is irregular, and the baby may need ventilation, most likely in severe encephalopathy. Levene's grading should be done every 8 hours or 12 hours to assess the severity and progression or resolution of encephalopathy. Remember, most of the mild encephalopathies would reverse within 24 hours. And also remember that this is a continuum. This is not that it is the hard-bound three different categories. The baby could be somewhere between mild to moderate, where the baby may have some features of mild and some features of moderate, and could be between moderate to severe as well. So these are not really very watertight compartments. You need to really look at whether the baby is somewhere in between that. As I say, if the baby has all the characters of mild, most likely this baby should recover within 24 hours, or the baby would progress to moderate to severe. A baby would not remain in the mild encephalopathy for beyond, usually speaking, 24 hours. Now, Thompson score, uh, uh, this is based on a hypothermia trial where this a worse score of 22 and a score of 15 or more has a positive predictive value of 92% and a negative predictive value of 82%, and high sensitivity and specificity for abnormal outcomes at 12 months. This is more perhaps has more parameters and perhaps more validated compared to the other two scoring systems, which are perhaps before this era of evidence-based medicine really set in, where we did not really look at the prognostication or the long-term outcomes of babies falling into mild, moderate, and severe. Although the classification system, Levine, and for that matter, Sarna, do give us some idea about the prognosis of babies. Now, Thompson score has tone, level of consciousness, seizures, posture, morose, grasp, suck, respiration, and fontanelle. Remember, it is very difficult to remember all these scoring systems. Though the best way is pick up one for your neonatal ICU, paste it on a notice board, and whenever the baby with asphyxia comes in, just mark the baby, look at the scoring system. Now, Sarnat and Sarnat, which has been the gospel, the Bible of neonatal encephalopathy scoring system, is the oldest one, as I said. Looks at some of the things like level of consciousness, neuromuscular control, complex reflexes, autonomic function, seizures, and EEG findings. Sarnat also, if you were to ask me at my time, there was Sarnat and Levine's. Now, Thompson is perhaps the gold standard. But even in Sarnat, if the baby has mild asphyxia, chance of severe neuromotor dysfunction at 2 years of age is very rare, although some problems may exist, minor problems may exist. For babies who are in stage 2 encephalopathy, these are babies who 70 to 80% of them are likely to do well as well as long-term neurodevelopment is concerned. And for babies in stage 3, either they die or have a poor outcome almost universally. Coming to initial stabilization and management, remember supportive care to maintain temperature, perfusion, respiration, metabolic status, and nutrition. I'll put it that way. Just prevent hypothermia, hypotension, hypocarbia or hypercarbia, hypoglycemia, hypocalcemia. These are some of the things that need to be prevented. So all hypos are hyper. If I was to quote from my teacher, Professor V.K. Paul, pathology, how to treat any disease is just maintain normal physiology. Look at the physiology. If we can reverse the pathology into physiology, then we've done our job. So just keep everything within the normal range: temperature, perfusion, respiration, metabolic status, and nutrition. Now, there is a catch here that therapeutic hypothermia can be offered to babies if you have centers nearby, and you can shift the baby to the center within 6 hours of birth. Temperature maintained between 36.5 to 37.5. Airway, we need to maintain airways always. Breathing, respiratory support if needed. Remember, hyperoxia is as bad as hypoxia. So do not target saturation more than 95%. That is for all babies. For all babies in neonatal ICU, there would be hardly any baby at your level which should be saturating more than 97% and is getting some oxygen. Circulation, maintain blood pressure within normal limits. A rough guide is gestational age in weeks is equal to the mean blood pressure. Now, most neonatal non-invasive blood pressure would give you mean blood pressures. Normal pulses and normal capillary refill time. Nutrition, IV fluids, if severe asphyxia, feeds can be initiated once meconium has passed and abdomen is soft. In fact, some of the babies on therapeutic hypothermia can also be fed, although complete feeding is usually not possible for babies on therapeutic hypothermia. Metabolic, avoid hypo or hyperglycemia. Calcium, if there is jittiness or seizures, or you can monitor calcium also. These babies can have, babies with very low calcium need to be given calcium even in the absence of symptoms. Vitamin K, if not administered at birth, needs to be administered once the baby comes under your care. Maintenance of seizures, we have a separate topic in itself. We'll talk about. So we monitor the vitals of the baby. As you can see, the best way is a multi-channel monitor where we have a ECG on the baby, a pulse oximeter on the baby, and we can look at the plethysmograph, we can look at the ECG. Capillary refill time. Now, this is not the right picture for capillary refill time. Sorry to state that. I got these pictures. Capillary refill time is always done on the central part of the body. Central part means you can do it on the forehead, you can do it on the chest. Press for 5 seconds and leave it and count 1001, 1002, 1003. Capillary refill time in the peripheries is affected by temperature, and that may not be an accurate marker of the perfusion of the baby. Respiratory distress monitoring, I think everyone knows at least one of the scores. You could either do a Silverman-Anderson scoring, but Downey score for term babies is more reliable. So, and Silverman-Anderson scoring for preterm babies with respiratory distress. So you could do either, but trend over a period of time is more important than a single score. But a single score more than 6 or 7, this baby might need some degree of respiratory support. Urine output, as I said, is a marker of prognosis also. So babies with poor urine output in the first few hours, you know that kidney has been damaged, and you know that then brain damage may follow. Abdominal girth monitoring, yes, you can do routinely also, or you can just do if there is a visual evidence that the abdomen is distended. For babies on feeds, if girth remains normal, or there is no increase in girth, then you can continue feeding the baby. There is no need for pre-feed aspirates. That we need to know. And blood glucose monitoring is important. We need to maintain euglycemia, neither hyperglycemia nor hypoglycemia. For that, IV fluids need to be tailored. Neurological examination is important. Once the baby has stabilized, you can do it in the first 24 hours once, and then follow it up every 8 to 12 hours to see whether the encephalopathy is progressing or recovering. So how do we monitor CNS? Levine staging every 8 hours, color, heart rate, capillary refill time, peripheral pulses, saturation and blood pressure, respiratory system scoring every 2 to 3 hours, abdominal girth monitoring, urine output more than 1 ml per kg per hour as a target, metabolic blood glucose monitoring every 6 to 8 hours for the first 24 hours, and you can gradually taper off if the baby is taper off monitoring if the baby is maintaining blood glucose, and management of seizures. So what is the window period? Remember, whenever the baby suffers hypoxia or ischemia, there is a primary neuronal death which we may not be able to salvage. The primary neuronal death, perhaps nothing is going to work because that is just an acute neuronal injury and the cell dies. Now, the secondary delayed neuronal death, which occurs due to cytotoxic mechanisms, this is the group of neurons that we try to save by doing some interventions. These are secondary neuronal death, and we can prevent them. This is a flow chart which, yes, you are expected to remember, but I don't know how many would remember as they go down the line. This is the mechanism of secondary neuronal damage. So release of excitatory amino acids like glutamate, which go on to postsynaptic receptors. Here you can act, which work on NMDA receptors, increase calcium ion influx, where you can act. Phospholipase, where you can act. Release of sequestered calcium, you can act. Proteases, you can act. So there are many places where you can work on. But clinically, if you were to ask me today, what we have only one thing. Now you can have hypothermia, which works at different levels. Obviously, it slows down the metabolism, so it works at different levels. Then there are NMDA receptor antagonists like magnesium sulfate, xenon, levetiracetam, and topiramate. Now, again, as of today, no evidence to suggest that these things work in isolation. Currently, we are looking at therapies which may work in association with hypothermia, not necessarily in association. This is more a bundle approach to treatment rather than single interventions which may be effective. These are calcium channel blockers, and they can decrease the intracellular calcium and perhaps then decrease the secondary neuronal injury. And then we have free radicals, which cause the reperfusion, which causes free radical injury, and avoiding high oxygen levels. I'll not say 100% oxygen, but avoiding hyperoxia can prevent that degree of damage. We know from evidence now, and it's been more than 2 decades. We know the evidence that resuscitating a term baby with air is better than resuscitating the baby with oxygen, at least initially. And then we could have free radical scavengers like allopurinol and desferrioxamine. Coming to hypothermia, cooling for newborns with hypoxic ischemic encephalopathy. Looking at the Cochrane meta-analysis, we have 11 RCTs, 1,500, more than 1,500 term and late preterm babies with moderate to severe HI within 6 hours of onset. Remember that combined outcome of mortality or major neurodevelopmental disabilities, the decrease is 25%. The relative risk is 0.75. So it is not that if you don't have hypothermia, you just cannot take care of a baby or the hypothermia facility is not available. But realize that good hypothermia facilities would need a level 3 neonatal ICU with round-the-clock care for the babies. It cannot and it should not be done in babies which are run by single pediatricians. It is for our institutions to really provide therapeutic hypothermia. And numbers needed to treat to benefit is 7. So you give hypothermia to 7 babies who need it, you might prevent a mortality or a major neurodevelopmental disability in 1 baby. For mortality, numbers needed to treat is 11. So you treat 11 babies, then you prevent 1 mortality in asphyxia. Now, I believe many people would have heard about HELIX trial. I'll not go into details of HELIX. HELIX trial was done in low and medium income countries, and it showed that hypothermia actually worsened the outcomes. Hypothermia for encephalopathy in low and medium income countries trial, which is the HELIX trial. Now, following this trial, there was a huge uproar in the science community that you just cannot say that low and medium income countries should not. There are many drawbacks of the study. Without going into the drawbacks of the study, I say National Neurology Forum came up with a position statement and guidelines for the use of therapeutic hypothermia. This is important from the point of view of medical legal aspects, that we should not use therapeutic hypothermia beyond these guidelines. That is a gestation age more than 36 weeks and less than 6 hours of postnatal life, with an admission temperature which is normal, and if they fulfill all the following criteria: a pH less than 7 or a base excess more than -16, APGAR score less than 5 at 10 minutes, or at least 10 minutes of positive pressure ventilation, history of acute perinatal event, and evidence of moderate to severe encephalopathy. All these need to be fulfilled for you to really put the baby on therapeutic hypothermia. Remember, MRI is the most, I was not very happy with these slides. MRI is the most important imaging modality in HI for early prognostication. But who is going to take a sick baby to MRI, prevent the baby getting hypothermic there and destabilizing there? I think this is more from an academic point of view rather than ordering an MRI. I have seen babies with asphyxia coming to me with a CT scan and an MRI in hand, which took 6 to 8 hours to get done. And the baby has lost that window period where we could do something, that the damage is full. I, as of now, without any qualms about this, would say do not get an MRI in the first 24 to 48 hours unless you are working in a very good institution where transport incubator could take the baby to the MRI room and then get the MRI done. Altered signal at the level of posterior limb of the internal capsule and abnormalities of thalami and basal ganglia in term babies, and that of white and gray matter at term equivalent age in preterm infants are strong predictors. Remember this for your theory, but do not go for an MRI for babies with HI in the first few days. I think we need to look into the social context. Babies who are asphyxiated are usually the babies who do not get good antenatal, good intranatal care. And these are the babies whose parents would not afford an MRI. And getting an MRI perhaps is hardly going to change the management of these babies. And now other investigations only in the presence of clinical pointers, I say sepsis screen you need to do for babies and blood culture to exclude in utero or acquired infection during resuscitation. In X-ray chest to look for pneumothorax malformations or poor cardiac function. If you have an echo, yes, go ahead and do an echo. Bedside echo is a reasonable investigation compared to an MRI because that can guide your treatment. Similarly, CT scan would be a waste of effort. Brain edema suggested by small compressed ventricles and intracranial hemorrhage of any sort can be picked up on CT scan. Same things, ultrasound again can give you some important information without destabilizing the baby. And EEG, if you have, adds to the information and adds to the prognostication of babies. And also to some extent, picking up seizures and treating them so that brain damage does not progress. How to prevent asphyxia, a good perinatal assessment with regular antenatal checkups, a high-risk approach, anticipation of complications during labor, timely interventions, a good resuscitation, a timely referral. Preterm brain protection would include antenatal steroids, which prevents IVH all grades, which prevents developmental delay. Magnesium sulfate in labor prevents cerebral palsy. Delayed cord clamping, even in preterm babies. And we are now moving on to the level of resuscitation with the intact cord. That's a different chapter altogether. But you need to know that perhaps that is feasibility has been shown, and to some degree, perhaps a better way of resuscitating babies than cutting the cord and shifting the baby under radiant warmers. Gentler ventilation prevents hypocarbia. Hypocarbia perhaps is worse than hypercarbia. So we always need to look at the ventilation of the baby, and if you can see the baby's chest moving from a distance, your CO2 is going to be low, and we do not want that. Golden hour strategies, delivery at a tertiary care hospital, delayed cord clamping, maintaining normal temperature and improving admission temperature, delivery room CPAP for preterm babies, and optimal use of oxygen. What are the poor prognostic factors? Need for post-operation ventilation for 5 minutes or longer, onset of seizures within 12 hours, refractory seizures not controlled with 2 drugs, severe HIE on Levine score or a Sarnat score or a Thompson score, and inability to establish direct oral feeds by 1 week. That means the baby has suffered significant damage and long-term neurodevelopmental outcome is perhaps going to be bad. All neonates who suffer perinatal asphyxia are to be followed up in a high-risk clinic, monitoring for normal things like growth and development and long-term neurodevelopmental outcome. Definitely a screening, developmental screening at 2 years of age is in order. And if the babies have delayed development, then a complete developmental assessment needs to be done.
Sir.
Key messages: initiation and development of hypoxic ischemic injury is complex. Close monitoring and supportive management works in majority of cases. Therapeutic hypothermia is an established therapy, but do not try that in standalone single person run neonatal ICUs. Different pathophysiology of asphyxia in preterm and term and different outcomes. I'll stop for 5 minutes here and take the questions if there are any, and then perhaps go to the next topic, which is seizures.
Good evening, Ashwini sir. Pratima this side, sir.
Good evening. How are you, Dr.
Yeah.
Pratima?
Yeah, I'm good, sir. Yeah, sir. MRI slide was actually kept only for, what to say, a pathophysiological purpose that if done at 24 to 48 hours, and I'm sure practically at our institutes, we are not doing MRI at all, even for prognostication. We are going for clinical pointers itself, sir.
Precisely. I want that message to go on to.
Yes, sir.
The question is, you have kept it for pathophysiology purposes, but the message sometimes goes across that perhaps getting an MRI in first 24 to 48 hours is important, which I think it should not go from an NF side.
Yeah. Yes, sir.
Any questions or any clarifications, or someone wants to say that they have learned something differently and would be happy
any
to
questions? You can unmute and ask. The students are actually first year postgraduates. I'm not sure कि निको posting अभी हुआ है neonatology or not, but still you can ask from the talk itself or from any material which has been posted this week.
Anything you may not have. Or you can just put it in the chat box, and we can just retrieve the questions. Okay, I can see one word as asphyxia mimics. Yes, asphyxia. There are many mimics of asphyxia, but the question is, once we go to the stricter definition of asphyxia, it is very easy to define. But things like sepsis can, in our country, sepsis would be a big mimic of asphyxia. Then, and especially for outborn babies, where the babies come late to you, some of the metabolic conditions can mimic asphyxia. Severe hypoglycemia can mimic asphyxia. Then some of the inborn errors of metabolism are pretty. Some of the inborn errors of metabolism are also known to mimic asphyxia, and something like non-ketotic hyperglycemias. Now, these are rare things. I think we need to look at common things: sepsis, asphyxia, common metabolic disorders like hypoglycemia. I would not go into details of the rarer things like IEMs. Yes, that is there. But as a PG resident or as a postgraduate or in pediatrics, I think we need to concentrate on common things first. Should we go on to the next slide? Next presentation, neonatal seizures. Okay, then if there is nothing more, then we go on to neonatal seizures. Okay. Now definitions. Anyone has seen Three Idiots? Definitions are there to remember, but then we need to look at how we can define it in a more simpler language. More complex is a sudden alteration in neurological function of a neonate, which could be motor, behavior, and or autonomic function. Remember, a seizure in the neonatal period is an emergency. The important thing is to recognize the seizure. Learning objectives of this talk is identify neonatal seizures, enumerate the causes of neonatal seizures, manage neonatal seizures, and wean anticonvulsant plan of followed. I think I need to show you this. Everyone see this video and then perhaps can comment whether this baby is having a seizure, one, and two, if yes, what is the type of seizure. Look at the eyes, look at the oral movements, and look at, yeah, this one. This is more easily detectable. This is more twitching of the eyelids. These are focal clonic seizures. Those are more automatisms or subtle seizures. This is again focal clonic seizures. You just see one hand twitching. Okay. International League Against Epilepsy classification of seizures and epilepsies. Now, this is an update on classification of neonatal seizures. Updated definition says an electrographic event with a pattern characterized by sudden, repetitive, evolving, stereotyped waveforms with a beginning and an end. The duration is not defined but has to be sufficient to demonstrate evolution in frequency and morphology of discharges. Although it has been suggested that 10 seconds may allow better interpretability, even shorter signal. Now remember that the updated definition lays emphasis on electrographic event. One thing. That is what we need to say. That to say an event is a seizure with 100% certainty, you need an EEG. But that is not always possible. Now, remember what are the causes of seizure in neonates? Commonest being HIE, followed by infections and vascular causes, and then metabolic, and then perhaps genetic and brain malformations. Classification of neonatal seizures can be based on electroclinical phenotype. It emphasizes the key role of EEG in the diagnosis of neonatal seizures, has implications for management and treatment. The problem is it should be acceptable to neonatologists and pediatricians. The neonatologists are very hard to convince. Second thing is these guidelines are made in the Western countries where everything is available and cost is usually not an issue. Whereas in our country, कितना देती है इवन द मर्सिडीज के लिए भी लोग यही पूछते हैं कि इसकी माइलेज क्या होती है सो फॉर babies as I said who suffer asphyxia or most of the babies who are sicker belong to a lower socioeconomic status and it is going to cost in the private sector. This last thing is actually the problem. Be applicable in all healthcare settings. Now having an EEG in all healthcare settings impossible. Now, classification could be clinical only, electroclinical only, electroclinical, that means electrical and clinical, and electrographic only. Now, clinical only seizure is defined as a sudden paroxysmal abnormal clinical changes without a definite EEG association. In electroclinical seizure, there is an associated EEG association. And an electrographic only seizure means the seizure is there only on the EEG, there is no clinical correlation of the same. Now remember, if a baby is critically ill or clinical suspicion of seizures, we do a video EEG, which is the gold standard, or an amplitude integrated EEG, which is slightly lower. There is no EEG abnormality. That means perhaps it's a non-seizure episode. If there is EEG abnormality and there's a clinical association, then it's an electroclinical seizure, which could be motor, like automatisms, clonic, spasms, myoclonic or tonic, or non-motor like autonomic or behavior arrest. Could be just a stare, or it could be something like a sudden change in color or a change in heart rate, something like that. Or it could be sequential, motor, non-motor followed by motor, or it could be unclassified. And then there is electrographic seizure only, which is there is no clinical signs of that. Remember, newborns have seizures which are exclusively focal onset. Thus, the initial division into focal and generalized is unnecessary. Previous terminology of subtle, focal, or generalized seizures is removed. Now, subtle are automatisms, which repetitive blinking, eye deviation, and steering, repetitive movements of mouth or tongue, or purposeless movement of limbs like cycling or swimming movements. Clonic is repetitive movements of the limbs or one side of the face. Tonic is continuous extension of the flexion of arm, continuous extension or flexion of arms or legs. And myoclonic is sudden jerky movements of the limbs. Now, automatisms could be unilateral, bilateral asymmetric, or bilateral symmetric. Clonic seizures could be focal, multifocal. Epileptic spasm can be unilateral, bilateral asymmetric, or bilateral symmetric. Myoclonic seizures could be focal, multifocal. And tonic seizures could be focal, again, bilateral, symmetric, or asymmetric. Now, this is just to describe what, if a baby has seizures and you need to describe it, you could describe it in any of the 5 types and then subsequent subtypes. Now, remember that combination of more sophisticated gene testing and video EEG monitoring allows the identification and stratification of distinct etiology-specific electroclinical phenotypes. Now, these days, genetic tests are more easily available. A clinical exome or a whole exome sequencing. These are the tests which have led us to find some of the rarer genetic causes of seizures, which are not so rare, we now believe in. So that is why hypoxic ischemic still tops the list of the causes of seizures, but you could have epilepsy syndromes, which are specific syndromes with specific clinical features, which can be picked either on an EEG and clinical examination or a genetic testing. Now, as I said, what if EEG is not available? In a baby with risk for seizures and baby with a suspected seizure, is the EEG available or not? If EEG is not available, then observed by an experienced personnel, yes, he says there is focal clonic or focal tonic seizures. It's a level 2B for saying that probable diagnosis of seizure. If there is other seizure types, then it's a possible diagnosis, which is even a lower level. But if the person observes says there is no evidence of seizures, it's insufficient evidence in the sense that you could have electrical only seizures also. And obviously there will be no clinical manifestation of the same. If you have a continuous EEG monitoring with video, then that is the gold standard. If it says there is seizures on the EEG, it is a seizure. If there is no seizure, there is no seizure. Now complete EEG is not available in most neonatal setups. You have amplitude integrated EEG, which is easier to do. You don't need all those leads. Now, a level 2A is a probable diagnosis of seizure if AEG correlate is there. And if it is not there, then there is insufficient evidence. So that is how we say. Now, the question is, what do we do with that? We'll just come back to that. Remember, we need to differentiate seizures from jitteriness. This is a common question asked. This is a common problem in the neonatal ICU phase. Abnormal eye movements are present in seizures. Predominant movement in seizures is clonic, a fast and a slow component. Movements can be stopped by passive flexion in tremor, in jitteriness or tremors, not in seizures. Movements are stimulus sensitive. That means you tap the bed, the baby might go into jitteriness. She doesn't go into seizures always. Associated autonomic change in heart rate or blood pressure or saturation is present in seizures, not necessarily in jitteriness. Neurological examination is usually abnormal in a baby with definite seizures, but in jitteriness, baby has normal neurological examination, and EEG has to be abnormal, as we know today, for seizures, which it is normal in jitteriness. So how to treat a child with seizures? First step is resuscitate if needed. TABC is the gold standard for neonates, opposed to ABC in the adults or older children. We get the child into a thermoneutral environment. We uh, keep the airway open, and we provide, if the baby is breathing, then nothing else to do, just monitor the saturation. Baby is not breathing, we need to provide positive pressures. Ventilation, keep the saturation between 91 to 95. Again, as I said, there is no reason ever to have a saturation more than 95%. Circulation, adequate circulation and IV access needs to be established as early as possible in any child with seizures. We do the samples, complete blood count, blood sugar, serum calcium, electrolytes, and a blood culture always. I'll say always because once we are taking the samples, if we take the IV line, we don't take the culture, we end up giving antibiotics and then deciding, okay, अब culture तो लिया नहीं था, लें या नहीं लें. Should we take it? Should we not take it? And if we take it, chances of having a negative culture are higher. Second step is if the blood glucose is less than 45, give a bolus of 2 ml per kg of 10% dextrose and start glucose infusion rate at 6 to 8 milligram per kg per minute. I believe some of the metabolic classes on metabolic disorders should have taught us how to make an infusion which gives you a glucose infusion rate of 6 to 8 milligram per kg per minute. But suffice to say that if you are to start 10% dextrose in emergency at a rate of 85 ml per kg per day, that will give a glucose infusion rate of 6 milligram per kg per minute. Remember, 10% dextrose or isolate P4 if you are to use, that is any fluid which contains 10% dextrose at an infusion rate of 85 ml per kg per day gives a glucose infusion rate of 6 milligram per kg per minute. You can safely start this and then do the calculations if you need to hike it or if you need to increase the fluid infusion rate or increase the concentration of glucose. If blood glucose is normal, collect sample for serum calcium, which we should have already collected. Give 10% calcium gluconate 2 ml per kg IV over 10 minutes. 10% calcium gluconate is diluted with equal volume distilled water and administered under cardiac monitoring. Now, cardiac monitoring could be EEG or it could be just your stethoscope. Do it slowly, should be under the monitoring of a doctor. Do not leave it to the staff nurses alone. This is one thing which can cause just cardiac arrest. Adding calcium to maintenance IV fluids does not suffice if the baby has hypocalcemia related seizures. Also realize that calcium can control seizures even if there is no hypocalcemia. There's a non-specific membrane stability action of calcium, and some of the seizures may be aborted with calcium, although they will recur very soon because calcium does not remain very high in the blood for very long. The first line anticonvulsant drug is phenobarbital, which is to be given 20 milligram per kg as an IV infusion over 20 minutes. You can mix it with saline, give it over 20 minutes. If the baby has no further seizures, do not start maintenance phenobarbital. One thing that you need to carry home. First episode of seizures controlled with phenobarbital, do not start maintenance phenobarbital. If seizures persist or recur after loading dose of phenobarbital, doses of 5 milligram per kg up to a total of 40 milligram per kg can be given. That means you can give up to 4 boluses of 5 milligram per kg. And then these babies need to start with maintenance phenobarbital at a dose of 3 to 4 milligram per kg per day. After 12 hours of the loading dose of phenobarbital, phenobarbital is normally used twice a day in neonates. Second line anticonvulsant drug is phenytoin or fosphenytoin. Remember, if I say phenytoin 20, that means fosphenytoin 30. Phenytoin or fosphenytoin 20 milligram per kg, phenytoin equivalent, IV over 20 minutes. Do not mix with dextrose containing solutions. It crystallizes. Use only with saline. If the line is running dextrose, stop that, flush the saline, and then give the bolus. Start maintenance phenytoin at a dose of 3 to 4 milligram after 12 hours of the bolus. If seizures persist despite the two anticonvulsants, you can use lorazepam 0.05 to 0.1 milligram per kg as IV bolus, or midazolam infusion may be considered if lorazepam is not available. Dose to be used is 0.15 milligram per kg loading dose followed by zero point 0.1 to zero point 0.4 milligram per kg per hour infusion. Do not use diazepam. Brilliant students can really put me in the chat box. Why don't you want to use diazepam in units? Which is the preferred second line anti-seizure medication for a newborn with seizures? Phenytoin, levetiracetam, midazolam, or lidocaine may be used as second line. These are the guidelines of International League Against Epilepsy. In a neonate with cardiac disorders, because phenytoin, lidocaine, and midazolam can have effect on the heart, more so phenytoin and lidocaine, levetiracetam is the preferred drug for babies with cardiac disorders. Meaning babies with asphyxia who have some degree of cardiac dysfunction or risk of arrhythmias, you may use levetiracetam as a second drug. But yes, a slow phenytoin also doesn't really cause too much of harm. Going to the stepwise management, ensure TABC, blood glucose. If glucose is low, manage hypoglycemia. Do serum calcium, give 10% calcium gluconate. First line, phenobarbital, single dose, not I'm sorry for that. First dose, no maintenance. If you need to use further doses, you use maintenance. Second line is phenytoin. Then you can use lorazepam or midazolam. And if continues to have it, then next line drugs. Transient metabolic problems such as hypoglycemia, or dyslipidemia, treat the cause, stop the anticonvulsant immediately. Seizures controlled with the first bolus of phenobarb, no maintenance anticonvulsants. Seizures controlled with multiple doses, start maintenance phenobarbital, stop phenobarbital once seizure free for 48 hours. Again, used phenytoin, stop phenytoin if seizure free for 48 hours, continue maintenance phenobarbital. Assess neurological status. If normal, stop phenobarbital. If abnormal, may continue. You may still stop it. We, as a unit, do stop it. If neurological examination is abnormal at discharge, may consider continuing phenobarbital in the absence of an EEG. But if you have an EEG and that is normal, I would still stop. Even otherwise, also, it is preferable to stop and then really see if there is recurrence of seizures, you may start phenobarbital again. If neurological examination is abnormal at 1 month and the baby continues to be on an anticonvulsant, it is better to consult a pediatric neurologist and decide on further anticonvulsant therapy because phenobarbital itself has some deleterious effect on the developing brain. Now, if a newborn has seizure and is controlled on current anti-epileptic drug treatment, when should the medication be discontinued? Following cessation of acute symptomatic seizures without evidence for neonatal onset epilepsy, anti-seizure medication should be discontinued before discharge, regardless of MRI or EEG findings. So this is the current guideline. So remember, most babies should be off unless you are considering neonatal onset epilepsy syndromes. Most babies should be off anti-seizure medication before discharge. Now, what is the role of EEG in a baby with seizures? Remember, amplitude integrated EEG is a lower form of EEG than the full lead EEG, the complete EEG or the conventional EEG. Now, in this study, 2015 et al., amplitude integrated EEG for detection of neonatal seizures is a systematic review. Out of 10 studies, accuracy of amplitude integrated EEG in compared to conventional EEG with a raw trace, a good sensitivity and a specificity, but in the absence of a raw trace, a low sensitivity. What does that mean? Baby has seizures, the AEG did not pick up. Remember this. Sensitivity, very difficult things to understand from a first year's perspective. But remember, sensitivity basically means picking up true positives. And EEG without amplitude integrated EEG without raw trace, sensitivity is low, but specificity is high. So if there is seizure, there is seizure. But if there is no seizure on EEG, it may still have seizures. The baby may still be having seizures. So conventional EEG remains the gold standard. Key messages: all neonatal seizures are focal in onset. Update the nomenclature based on motor and non-motor semiology. For diagnosis, EEG has a stronger role, but unfortunately, bedside EEG is unavailable in most neonatal ICUs across the country. Phenobarbital continues to remain the drug of choice. Levetiracetam comes a close second after phenytoin as a second line drug, and try to stop antiepileptics before discharge. I shall stop my talk here. I have something in the chat box. Let me see. NAHs may have normal neurodevelopmental outcome. HI stage 2, as I said, if you look at the original SARNAT staging, 70 to 80% babies would do well. So it is not that HI stage 2 may not have normal development. HI stage 3, very unlikely, but this never, remember, as you go higher up in experience, you always say never uh, in medicine, because that can happen. So never lose hope on that. I've seen myself in even in All in Nature of Medical Sciences, New Delhi, that once some senior person says this baby is not going to do well, and you see the baby at 2 hours walking into your OPD, and that to you seems like a miracle. So do not just, sir, is neurological examination not necessary? Neurological examination is necessary, but not to discontinue anti-epileptics before discharge. Irrespective of neurological examination, you may stop if you are not considering epilepsy syndromes as a diagnosis. Diazepam can cause adverse effects like apnea and hypotension, but diazepam also has a preservative, which leads to increased risk of bilirubin encephalopathy. So that is also one of the reasons why you will not use diazepam. Secondly, it has a very long duration of action compared to other drugs. So diazepam, I would be wary of using diazepam. The duration of action of diazepam is large. Sir, when do we do Hines scoring? Now, this is a method of neurological examination. You do it after discharge. It's not usually done. You can do it in the neonatal ICU also, but document what is happening to the baby in the neonatal ICU and then follow that up with the evaluation at 3 months, and that could tell you whether the baby is doing better or not. That is only about HINE, Hammersmith Infant Neonatal Examination. Anything else? Let's stop the share part at least. If anyone else, Pratima, are you there? So if there are no more questions, we'll just finish the session here. And it has been great interacting with some of the new stars, I believe, of pediatrics and neonatology. And hopefully you are getting an opportunity to learn the latest in neonatology. Yes, do we have a question? And I hope these sessions do really help you in improving the care and also the learning that you go through. Um, mm, as an executive member of NNF, I feel pride that yes, NNF has taken this initiative to really get basic neonatology to the first year PG residents. Thanks, everyone. I'll stop the session now, unless someone really wants to ask another question. So thank you, everyone. Good night. Enjoy your dinner.